Thank you all for participating in today's media briefing, our 29th since the start of the pandemic. These press conferences are a reflection of UPMC's ongoing commitment to provide timely and accurate information for all. Today, we're delighted to be joined by Dr. Meredith Chuck, Allocation, Distribution, and Administration Lead in the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. Thank you for joining us today, Dr. Chuck. Also, we have Tammy Minier, UPMC's Chief Quality Officer, Dr. Steve Evans, a surgical oncologist at UPMC Hillman Cancer Center, and Dr. Don Yealy, UPMC's Chief Medical Officer. They will explain the FDA's recent expansion of the eligibility guidelines for COVID-19 monoclonal antibody treatment, as well as UPMC's success in making this life-saving treatment easily accessible to all. We'll also discuss two Learning While Doing initiatives UPMC has launched to answer key questions about COVID-19 vaccine efficacy and monoclonal antibody use. After their remarks, we'll take your questions.
So let me take a moment to try to explain our relationship with HHS and why Dr. Chuck is joining us. A couple months ago, UPMC met with Dr. David Kessler, who is the Chief Science Officer within the White House COVID-19 response team. Dr. Meredith Chuck and the others leading in the Dr. Meredith Chuck is one of the others also leading with the Biden administration this same COVID-19 response effort. So knowing that COVID-19 is here and going to be here for a while, and that not all people have responded to the vaccine that's available, they asked for our help in promoting monoclonal antibodies. We said as an organization, we'll do you one better. We'll study the effectiveness of monoclonal antibodies in reducing hospitalizations and death, and we'll do a trial comparing the effectiveness of all monoclonal antibodies available. The federal government supplied the monoclonal antibodies we needed to treat our patients and patients from other health systems as well, because many are not as well equipped to provide this treatment to patients. We have been actively engaged with the team led by Dr. Kessler, sharing the results we shared with you in March with tremendous effectiveness of monoclonal antibodies in keeping our patients out of the hospital. But we also shared with them that only 1/3 of the people who could benefit from monoclonal antibodies were permitted to receive them by the FDA's emergency use authorization. We are delighted to know that they have listened to that feedback and have broadened the criteria so that virtually all can receive this potentially life-saving treatment. We also know that masking and distancing continue to evolve and are relaxing. Monoclonal antibodies will be an ever more valuable treatment to keep hospitalizations and deaths low as they possibly can. Unfortunately, COVID-19 is not completely going away. And even though the vaccines are very effective, and I encourage all of you, please consider getting your vaccine, it is still possible to get COVID-19 after being vaccinated. There are certain particular patients, those with cancers, organ transplants, or certain diseases for whom the vaccine may not work as well. And there are many people who are still not vaccinated who may never agree to be vaccinated. Because of that, I'm so excited to share with you that UPMC is one of the first in the country to fully implement the FDA's expanded emergency use authorization for monoclonal antibodies. And we've done so across our entire system. All of the regions we serve, from New York to Maryland, Pittsburgh to Williamsport. Thanks to our close collaboration with the federal government and their willingness to make monoclonal antibodies abundantly available, UPMC has seen a 25-fold increase in their administration. Our research shows that this treatment significantly reduces the risk of hospitalization and death if given early after diagnosis. As a reminder, monoclonal antibodies are a treatment we give through a one-time IV infusion. They're just like your own body's antibodies, but the treatment gets them to you faster than your body can make them. They help your immune system quickly destroy the virus before it can harm you. We have 46 locations where we can give this one-time treatment. dedicated safe infusion centers, and every UPMC emergency department. We also can bring it to patients in their homes, long-term care facilities, and behavioral health centers. The expanded eligibility criteria include just about everyone. Basically, any adult who is slightly overweight, smokers or people with just about any lung condition, people with most chronic diseases, including diabetes and high blood pressure, pregnant women, and patients with immunosuppressive conditions. This is really just a partial list of the eligibility. The most important thing is if you are diagnosed with COVID-19, even if your symptoms are mild, even if you've been vaccinated, ask about monoclonal antibodies. There's a good chance you're eligible, and they work best the sooner we can get them to you. So with that, I'd like to turn it over to Dr. Stephen Evans.
Thank you, Tammy. As a surgical oncologist, I treat patients who have cancer. Virtually all of them will qualify for monoclonal antibodies if they tested positive for COVID-19 and had symptoms for less than 10 days. I'd be devastated to learn that one of my patients contracted COVID-19 and didn't get this effective therapy in a timely fashion. Because of their immunosuppressed system, their odds of ending up in the hospital or intensive care unit is high. I'd hate to help them battle cancer only to have COVID-19 harm them. So despite our best efforts, we can't always keep and avoid getting COVID-19. This disease has disproportionately impacted communities of color. But we at UPMC have taken every precaution to mitigate any racial disparity in our administration of this life-saving treatment. Black, brown, and white all are receiving this treatment at equal rates. This wasn't always the case. At the very beginning of the UPMC's experience with monoclonal antibodies, people of color were receiving this treatment at a much lower rate. UPMC saw this gap and immediately began a multi-pronged approach to improve access. Drawing heavily from our success with improving access to COVID-19 vaccinations, we've made it easier for people to get treated by adding infusion sites, offering it in the emergency departments, and bringing it into people's homes. We've created educational flyers and resources, giving our clinicians the tools they need to talk about monoclonal antibodies with their patients and set them up for treatment. We called our Black and brown patients who received infusions to check in and asked about their experiences, looking for ways we could improve. We've handed out easy-to-understand brochures with patient testimonials featuring patients of color in all the communities we serve. Within a month, the disparity in infusion rates by race was gone. It wasn't easy, but nothing worth doing ever is.
So as everyone knows, the vaccines are absolutely the way that we will get ourselves back to some sort of normalcy. But what we also want everyone to know is that there is a therapy available for high-risk patients who do get COVID-19, and those are the monoclonal antibodies. Tammy had told you a bit about the eligibility criteria, and we just heard from Dr. Evans about the great partnership that UPMC has been with the federal government and their ability to increase access to these important therapies, especially ensuring access for their most vulnerable communities. And it's really wonderful to hear. Just as a bit of a background, we'll do some of the background first. There are two authorized products that were authorized by FDA for emergency use for adult and pediatric patients who are at high risk for disease progression for COVID-19. And those are authorized initially back in November based on some initial clinical data from early phase clinical trials that suggested the possibility that these really had the ability to keep high-risk patients from progressing to severe disease and keep those out of the hospital. Since that initial authorization, we've had readouts from a number of larger clinical trials from a number of the products and some observational data, such as we'll hear from UPMC as well. And really those have confirmed those early results about the ability of these products to keep our high-risk patients out of the hospital. And because of this new data, the NIH COVID-19 Clinical Trial Guidelines Committee is actually now recommending both of these monoclonal antibodies for high-risk outpatients with COVID-19. So just as a bit of a recap, eligible patients have to test positive for COVID-19. This can be a PCR, it can be a rapid test. Doesn't matter the type of direct test. They have to meet the high-risk criteria, which we heard a bit about and was just expanded recently from FDA and really gives providers a lot more latitude in assessing the risk-benefit and assessing the high-risk nature for each of their patients. And patients have to have started their symptoms within 10 days of the therapy. But what we really know is earlier is better. So it's really important for patients and providers to be aware of this therapy so that high-risk patients can be treated as soon as they start with symptoms and get this therapy early. So we talked a little bit about the high-risk criteria. Again, gives a lot of latitude. It aligns with the CDC definition of high risk. So I encourage you to look at the FDA fact sheets and visit the CDC website for more information. And with this expanded eligibility criteria, there are more patients who are eligible to receive these therapies. So we really encourage all providers to be aware of how to get this therapy for their high-risk patients so that we can maximize benefit. UPMC has a lot of resources for providers. We also have some federal resources on a website called combatcovid.hhs.gov. We encourage you to visit that. There are a lot of patient resources, provider resources, and other information so that, again, we can maximize this important therapy. So again, thank you so much. Apologize for the technical difficulties and look forward to the discussion.
Thank you, Dr. Chuck. We look forward to the media questions and the discussion that will follow. Before that, let me turn to Dr. Don Yealy. Dr. Yealy.
Thank you very much, Dr. Chuck. UPMC is and has been committed to learning while doing. That means we treat you with the best care that's available as we discover together with you the ways to improve upon care. It's what you expect from a world-class academic medical center. It's what we'll continue to deliver for you. I'm pleased to share that we are conducting a study, the largest of its kind anywhere, to learn more about the monoclonal antibody treatments that are available. Right now, there are 2 approved treatments. There will be more monoclonal antibody therapies available soon. What is important to know is if one or the other works better, whether they work better in different types of the virus or in different patient populations. We need to know if they're the same or different. UPMC launched what we call the Optimize C19 Trial. And what we did is put together something that not only allows us to give the therapy, but to continuously analyze our patient therapies and the outcomes from those therapies. And that makes it available to us to learn much more quickly than we did in the past to find out which treatment works better than another and under what conditions. We use this same exact learning while doing UPMC approach when we investigated the use of steroids that showed that they helped in seriously ill COVID-19 patients, and also in blood thinners that help in the moderately ill COVID-19 patients. As any new monoclonal antibody therapies are introduced, we'll include them in our efforts. This is possible because of the tremendous local expert teams that we've put together that are working closely with our federal partners. Together, we share a commitment to promoting evidence-based treatments that are analyzed with both rigor and with speed, not just one or the other. Thanks to Dr. Chuck and her colleagues, we've been able to get the monoclonal antibody therapies that we needed to ensure that our trial is both fair and informative. We will share the results with you and our peer review platforms as soon as they're available. Another study that we've launched is called COVICS, C-O-V-I-C-S, and it's built on the results that we shared with you last month. Those results that we shared with you showed that only half of our most immunocompromised patients, that is people with a blood cancer, produced antibodies against COVID-19 after vaccination. In this next effort that we're talking about, another learning while we're doing effort, we are collecting blood samples from hundreds of our immunocompromised patients, including those with cancer, organ transplantation, HIV or AIDS, autoimmune diseases, and the frail elderly. What we learn about the responses to COVID-19 vaccination will help us inform how we can care for these patients moving forward. The FDA and other federal agencies have done a tremendous job distributing vaccines to us and making sure that those vaccines are very effective against COVID-19. And I can say from firsthand experience, their work in promoting and making available these monoclonal antibodies has been a success. For us to put COVID-19 in a better place, it's going to require a mixture of both vaccines and treatments to tame the disease. And our federal partners have been phenomenal to work with in this account. We look forward to exploring further expansion in the use of monoclonal antibodies, including as potential prophylaxis to prevent COVID-19. Prophylaxis means getting it before you're sick, potentially even before you've been exposed. This could be helpful in many, particularly the people who are most vulnerable to have a bad outcome. This type of activity will require clinical trials, and UPMC stands ready to perform those trials using our fast, efficient, rigorous learning while we do approach. We're overjoyed that COVID-19 cases are dropping in our communities, but this disease is not going completely away. While we all start to get back to normal, UPMC will continue to protect the vulnerable, offer the best possible prevention and treatments for all of our patients, and define the care of tomorrow and for the future.
Thank you, doctors. Thank you, Tammy. And now we'll take your questions from the media, all of whom are joining us remotely online. To ask a question, go to the participants icon at the bottom of the page and press the raise your hand button. That will put you in the queue. I will read your name and your line will be unmuted for you to ask your question. Please remember to unmute the microphone on your end. We will try to call on as many different media outlets as we can in the time we have allotted. First question. Dr. Ely, you mentioned the possibility of giving monoclonal antibodies prophylactically. Why and how would that work?
Thanks for the question. Right now, we're authorized only to give monoclonal antibodies to people who have tested positive for COVID-19. In other words, they have the infection. Some people, particularly those with certain cancers, organ transplant recipients, patients with autoimmune diseases on therapy, and the frail elderly, simply don't mount an immune response that may be strong enough. They don't have a well-functioning immune system. Their body may not be able to make the antibodies at all, or at least in not enough amount to protect them, and they can't fight infections as well as many others can. While they can get COVID-19, they have very little defense, and they can get sick very, very quickly, and we've known this for a long period of time. When we give you monoclonal antibodies, they not only help you fight the infection from the minute we give them to you, they stay in your body for an extended period of time, sometimes for several months. If we give monoclonal antibodies proactively, say at the start of cold and flu season, to the most vulnerable people, and if they happen to be exposed to or get COVID-19, they will have protection that they couldn't have created themselves. They will have antibodies that help disable the virus before harm is done. We already give prophylactic therapies, that is, treatments in advance, to vulnerable patients for other diseases like fungal infections and pneumonia. We believe that monoclonal antibodies have a great potential to be a preventative measure and would allow immunocompromised people to join the rest of us in getting back to normal life.
Thank you, Don. Dr. Chuck, is there anything you'd like to add?
Apologies. No, thanks, Dr. Yuli. That was a great overview. And actually, we are definitely focused on outreach and provider education for those immunocompromised patients who can currently benefit if they get COVID-19. And we look forward to the possibility of being able to use these therapies in a prophylactic way.
Thank you. Next question, Paul Goff, Pittsburgh Business Times. Paul, please go ahead.
Hi, thanks for taking my question and having this. This is a two-part question. One is, you mentioned about that obviously you can get COVID-19 even if you have the vaccine. What have you seen in terms of people who've been vaccinated getting COVID? You know, what's the kind of percentage of that? And then at the same time, is there any difference in how you treat them with monoclonal antibodies or the outcomes if you've been vaccinated and then you get monoclonal antibodies?
So let me answer the second question first. I apologize for going out of order, but thank you for the questions, Paul. Once you have COVID-19 infection and are eligible under the current authorizations, the treatment is agnostic. It doesn't care whether or not you've been vaccinated or not before. So we treat you exactly the same. That's a very simple answer. It's a short infusion, usually takes less than an hour. It's very, very safe. And as we've shared before, it's incredibly effective in bending the disease outcome. In other words, you're much less likely to need hospital care or to have a serious or bad outcome after getting monoclonal antibody therapy if you get it early. So if you get sick or if you come to know of a positive test, ask early about it. Don't wait. It works better before the disease is entrenched. The second question you asked about is what does the infection rate look like? We have our own UPMC experience, and then recently we've gotten both nationwide and Commonwealth-wide information on this. And in general, let's step back for a second. The vaccines were designed to prevent serious infection and death, and they do that exceptionally well. They were never designed to make sure that if you came in contact with the virus, that the virus couldn't have a temporary home in your body, but it just really wouldn't get to the serious nature that would require hospital care or death or serious outcomes. We've seen the same pattern in our UPMC experience that has been seen across the country. Only 2% of people that have been vaccinated and eventually developed serious infection went on to have death as an outcome. That's way diminished from other types of exposures. And about 4 or 5% showed any signs of an infection. We've not seen in our communities death at anywhere near those rates, and we've seen a little bit lower amount of clinical infections. So in our eyes, the vaccines are working exactly as advertised, and we knew that some vulnerable people would still be at risk even with vaccination. It's still a good idea to get your vaccination. It's a better idea that if you feel sick or if you have a positive test, to let us know with or without a vaccine so we can offer the monoclonal antibody therapy.
Thank you. Dr. Chuck, anything to add?
I just want to reemphasize one of the comments that Dr. Yealy said about earlier is better. Again, the treatments are authorized to be given within 10 days of symptom onset, but we really know earlier is better. So it's important for those high-risk patients to know about the therapy even before they get sick, so that at the first onset of symptoms, they're able to get tested and talk to their providers about monoclonal antibodies.
Thank you. Next question, Bill Kibler, the Altoona Mirror. Bill, please go ahead.
Hi, thank you for taking this. Is there any idea how many people could be saved by monoclonal antibodies, say in the next year? Any idea of that?
I think that's a good question for Dr. Chuck to start with. Dr. Chuck?
Sure, happy to. So what we do know from some of the clinical trials that have been run, we look at something called a number needed to treat. And that is information about how many patients would you need to treat to prevent a particular outcome. And the average numbers that we generally use is that it would take 21 patients to be treated with a monoclonal to prevent a hospitalization and 52 to prevent one death. So those are the general numbers we use from the clinical trial data that we have. So it has the ability to really have a profound effect.
Yeah, and to put that into context, you may think, what does 1 in 20 or 1 in 50 mean? There are a lot of therapies that we all think about and know to be very, very effective that this is a better performance for. Those are really phenomenal numbers.
Great. Next question. Dr. Evans, while we await the results from UPMC's Immunocompromised study, what are you telling your patients to do to stay safe?
Well, first of all, get vaccinated. It is possible that the vaccine won't work, as we've discussed, but it's also possible that it will. So encourage those around you to get vaccinated. And for now, continue to wear a mask and avoid crowds if you're immunocompromised. We don't believe you'll have to do this forever. Like Dr. Yealy had mentioned, we're doing research to find out other options, such as the prophylactic treatment, as mentioned. This is very valuable in protecting our most vulnerable citizens and populations. Finally, if you think you may have COVID-19, get tested. And if your test is positive, ask for monoclonal antibodies right away. Our contact for UPMC's information is upmc.com/antibody treatment, and we will provide as much information as needed.
Thank you. Next question, Tom Davidson, Tribune Review. Tom, please go ahead.
Hello, can you hear me?
Yes, we can.
Thank you for taking the question. I wondered, are there any side effects or risks that have been identified with receiving the treatment, or is there anybody who actually can't be treated in this fashion, with the monoclonal antibodies?
Dr. Chuck, let's start with you.
Sure. So the most significant side effects, which are rare, is the potential for an infusion-related reaction. And that is the reason that these need to be given in a healthcare setting with folks who are able to treat an infusion-related reaction and activate emergency services as needed. But again, those are rare. In terms of patients who are not able to receive it, currently there aren't any contraindications. So it's really at the physician discretion for who's available based upon the eligibility criteria in the emergency use authorization.
And maybe to add a little bit more granularity, at UPMC, we've given nearly 2,800 doses of monoclonal antibody therapy. When I'm not sitting here on a panel with you, my job is to be an emergency physician. I'd be the person who would see you if there was a reaction. I have not seen anybody with a reaction that required further medical care based on monoclonal antibody therapy. They look to be very, very safe and a good choice for virtually everyone who qualifies under those conditions that we talked about.
Okay, again, to ask a question, go to the participants icon at the bottom of the page and press the raise your hand button. That will put you in our queue. I'll read your name and your line will be unmuted for you to ask a question. So next question, Danny Fitzgerald, Beaver County Times. Danny, please go ahead.
Great, thank you so much. My question is, I'm not sure if you guys went over this already, but is this something that doctors should be offering to patients who have already tested positive, or do patients just have to ask to receive this themselves?
Thanks, Danny. That's a great question. We've actually tried to implement multiple different ways of providing access. So yes, we've been working to educate all of our physicians to offer this to patients that do test positive. But we also have the numbers and information that we've shared where a patient can just call directly themselves. And in calling directly themselves, we will help navigate through the process to make sure they are able to receive them, and also work really hard to tie back to the community to make sure their local physicians are aware. So multiple avenues. The most important thing is to ask your doctor, call us, and we'll get you through the process.
Thank you, Tammy. We're nearing the end of our time that we've allotted, and I'd like to turn it back to Dr. Chuck for any closing remarks she may have.
Absolutely. So again, thank you for this opportunity to discuss this important therapies. We thank our partners at UPMC for really the modeling how to make this therapy widely available, educating patients and providers so that we can really maximize the use of this important therapy for the improvement of all of our high-risk patients. Thank you very much.
Thank you. And thank you again, Doctor, for participating in today's press briefing. And that concludes the time that we have allotted. Thank you all for participating. In about 45 minutes, we will email media attendees a link to download high-definition footage of the entire briefing, which we encourage you to use in your news reports. Reporters with follow-up questions are encouraged to contact our UPMC Media Relations Department at upmc.com/media. And please follow at UPMC News on Twitter for frequent updates. Thank you very much.